Hi, very good morning. I am Dr. Janak Patel, MD, General Physician. All my video lectures are mainly for educative purpose only. In continuity with previous lecture series regarding CNS examination and neurological topics. Today we'll be discussing on localization of lesion when there is a stroke. So localization of neurological lesion in a person with a stroke. So again, history is very important, followed by physical examination. Then we have to localize where is the lesion, anatomical lesion. Then which part of the nervous system, that is either cerebral hemisphere, pyramidal tract, extrapyramidal tract, which part physiological, what type of damage it is. And then we try to find out why there is a damage, that is etiological. And then finally we put functional diagnosis, which will include where, what and why. So that will be dealing. So first thing, always try to identify, is there any CNS lesion? It is due to CNS or not? It is due to nervous system or not? And then we try to answer these questions. Where is the lesion? That is site. What is the lesion? That is physiological. Why is the lesion? That is etiology. And then we put the final diagnosis. So final diagnosis will include everything, that is functional, anatomical, physiological and etiological. So it is always said that localization of CNS lesion without CT or MRI should be possible if you do proper good history followed by a good CNS examination. So keep it simple, not stupid is always the best way. So neurological examination always say you can see a lot just by observing, but you will be able to see only what you know. So your knowledge should be upgraded. So we'll try to upgrade that particular part. So practice, practice and practice. Practice makes man perfect. So we'll be trying to go through that. So all this standard CNS examination will include higher function, cranial nerves, motor system, sensory system, reflexes, posture, gait, equilibrium, involuntary movement, coordination, cerebellar examination, sphincter, and if a person is unconscious, then examination in an unconscious person, autonomic nervous system, spine, skull, meningeal signs, etc. So these are all the things we examine. And after examining, we should not forget even this, that is meningeal signs of irritation like Brudzinski, Kernicks, neck stiffness, and brainstem damage in the form of a dorsal movement, caloric test, and posture. We call decerebrate posture, decorticate posture, and we also say that person with a complete flaccidity. So your aim is to confirm the CNS lesion. Then we want to locate where is the damage. We want to find out what is the cause of damage, that is etiology. And then after making a proper diagnosis, we can go for management. We can decide regarding a prognosis and what will be the morbidity or what will be the mortality. So we can decide regarding that. We already mentioned regarding this that infections, most common etiology in CNS is infections, trauma, vascular, tumor, degenerative disorders, congenital defects, genetic defects, immune mediated, nutritional disorders, toxic effect of drugs and chemicals, iatrogenic, idiopathic, etc. So while localizing the CNS lesion, we should be perfect regarding a descending tract as well as ascending tracts. As we are going to do deal regarding the stroke part of it. So this will be a very, very important thing to know regarding a descending tract, particularly corticospinal tract. We have already discussed before. So roughly, corticospinal tract starts from the cerebral cortex. Then all the fiber will converge at internal capsule. The portion between cerebral cortex and internal capsule is called corona radiata. As it descends down in a midbrain pons and medulla, it will give out a fiber to the motor cranial nerve nucleus. We call cortico-bulbar tracts. In lower part of medulla, 90% of the fiber will cross to the opposite side in the lower part of medulla. That is lateral corticospinal tract. 10% of the fiber will remain on the same side. These are called uncrossed corticospinal tract, or we call anterior corticospinal tract. It will cross before ending, and both will end on an anterior horn cell nuclei. And from there, you will have an alpha motor neuron which will be supplying to via anterior spinal nerve root. It will be supplying to extrafusal fiber of a muscle, and that portion is called lower motor neuron. So this will be the entire part as far as a pyramidal tract is concerned, or we call corticospinal tract. This is what you can see, that these fibers are getting crossed at the lower part of medulla, and then it is ending in an anterior horn cell. These are uncrossed fiber. Before ending, it will cross to the opposite side, and then it will end in anterior horn cell. Indirectly, both the fiber, that is lateral corticospinal tract and anterior corticospinal tract, both will end in anterior horn cell of opposite side. So they control opposite half of the body. So this particular is very, very important. Now if you look here, these are the fiber which descend down in a midbrain, pons and medulla. In lower part of medulla, they cross to the opposite side, and then they supply muscle. So in a cortex, if you get a damage, it will be always opposite half of the body. In medulla also, it will be opposite half of the body. If you get a damage in anterior horn cell, you will have a lower motor neuron type of damage on the same side and at the level, but below the level it will be upper motor neuron. But if you get the damage to corticospinal tract, then you will have upper motor neuron damage on the same side below the level of damage. So below the level of the damage, upper motor neuron; at the level of the damage, lower motor neuron; and above the pyramidal crossing, pyramidal tract crosses at the lower part of medulla, it will be on the opposite side, and below the crossing, it will be on the same side. So this is a one small history. 62-year ABC, male person, a poor socio-economic, comes with it. He is a right-handed. Chief complaint is weakness of left upper limb and left lower limb since 4 days. Slurred speech, deviation of angle of mouth to the right side since 4 days. So this was the complaint. This clearly suggests that the person has got a left side hemiplegia. Now, after examining regarding the weakness, you will be able to put them into a hemiparesis or hemiplegia. So that will be after examination. But at present we say that it will be motor weakness on opposite side. Upper limb, lower limb involved, so motor weakness on opposite side. Now, here you have to look at the pattern of weakness. Here the person has come with almost hemi. The onset is little, if you look at the history, since 4 days. So it is not abrupt. So it is little gradual over minutes and hours. Now if you get in a history, if it is progressive, it will be more in favor of thrombosis. But if it is non-progressive, it will be more in favor of embolism. Then you have to look at the associated symptoms. Now, person is fully conscious. As person is fully conscious, there is less chance of damage in the pons and medulla, as well as extensive damage in a cortex is also less likely. Person doesn't have headache, vomiting, so there is no evidence of raised intracranial pressure. Person doesn't have seizures, so cortical damage is nearly out. There are no abnormal movement, there is no imbalance, so cerebellar involvement is also out. Now we'll be approaching further. So from history you have to make out whether it is upper motor neuron or lower motor neuron. So that should be established, and that will be after examination. If it is a lower motor neuron, it will be anterior horn cell or motor root or plexus or nerve or myoneural junction. This is less likely. It is more likely to be upper motor neuron because it is an extensive damage. Upper limb as well as lower limb involved. You can see here, upper limb and lower limb both are involved with slurred speech. So some of the cranial nerves are also getting involved, and there is a deviation of the angle of the mouth. So probably 7th cranial nerve is also involved. So while localizing the lesion, you will have to clinically, at least we can say that it is unlikely to be hemorrhage, because in a hemorrhage it will be rapidly progressive, while here there is no further progress, so it is less likely. It is more likely embolic stroke because it is non-progressive. Unlikely to be internal capsular stroke because if the person is having extensive damage in both upper limb and lower limb, which will be usually dense hemiplegia, and if the person is having a brainstem stroke, it will be contralateral hemiplegia. So on one side you will have lower motor neuron cranial nerve palsy, and on opposite side you will have hemiplegia, which does not appear because mouth is deviated to right side. That means right side contraction of muscle is there. Left side must be affected, and probably it is upper motor neuron facial. Hence, this will fit more with left side hemiparesis or hemiplegia. So there is either damage at the cerebral cortical area or in internal capsule. So whenever you want to make out, you will have to look at where is the lesion, what type of lesion, and then you go for whether it is embolism, hemorrhage, infarct, demyelination, what it is. And this you will have to establish by a good history, good CNS examination, etc. So you will have to establish that. Now here the person is having one person who has been presenting with all the 4 limb weakness due to spinal cord lesion above C5. The lesion is involving pyramidal tract, posterior column, spinothalamic tract due to extradural compressive etiology. Now this particular you can make out the person has got quadruparesis. As far as the anatomical diagnosis is concerned, cervical cord above C5 level. Which portion is being involved? Pyramidal tract, spinothalamic tract, posterior column are involved. So probable etiology is extradural, extramedullary compressive etiology. So that is how you have to put together. So here sudden onset of motor weakness on right side with global aphasia due to suspected stroke. So here you can see that hemiplegia with global aphasia, cerebrum and left middle cerebral artery territory, motor and language area is being affected. So, and being a vascular etiology will put the diagnosis of stroke. So you have to establish that. Now, as far as a stroke is concerned, you will have to find out whether it is traumatic, vascular or due to infection, or if it is tumor, vascular or infective pathophysiology as a chronic onset, because by and large the stroke is mainly because of a vascular etiology. So you will have to establish among a vascular etiology whether it is embolic, it is ischemic heart disease or it is because of thrombosis. So that you will have to find out, and then you will have to make out whether it is a crossed or uncrossed. Uncrossed means ipsilateral, or it is cruciate. In a cruciate, upper limb on ipsilateral side and lower limb on a contralateral side. If a person comes with this presentation, it will be a damage at the level of medulla where the crossing is taking place. If it is a cross hemiplegia, the damage has to be in a brainstem, that is midbrain pons or medulla. If it is on a ipsilateral side, it is always below the medulla or in a spinal cord. That is most likely. And if a person has got a full power gone, total, then we call as a hemiplegia. If there is a reduced power, we call as a hemiparesis. And if it is because of damage prenatal, natal or postnatal, it is invariably, very commonly we call it a cerebral palsy. If there is a dense hemiplegia, upper limb and lower limb involved, it is invariably internal capsular lesion. If there is an upper limb more involved as compared to lower limb, it is called brachial hemiplegia. If lower limb is more involved than upper limb, it is called crural hemiplegia. And if cranial nerve on the same side, lower motor neuron, and opposite side, you get hemiplegia, we call contralateral hemiplegia, and ipsilateral lower motor neuron cranial nerve palsy, we call that as a cross hemiplegia. These are all the terminology which are being utilized, and this will be there if the damage is there in the brainstem. If we are aware of all this, we'll be able to localize very well. So now, if a person presents with hypertonia, brisk reflexes or clonus, plantar is extensor, and there is an evidence of Hoffman test or Wattenberg test or finger flexion reflex, there is no wasting, no fasciculation, power is just diminished, we'll mention that as hemiparesis. But if total power gone, we'll label that as hemiplegia. But once the person recovers, the person will have hypertonia, dip tendon reflex will be brisk, clonus will be present, Babinski sign will be positive, Hoffman test will be present, Wattenberg test can be demonstrable, finger flexion can be demonstrable, and there will be no wasting, no fasciculation, that will be peculiar. So when there is a lesion at cortex or internal capsule or brainstem or spinal cord lesion, you can have upper motor neuron lesion, where depending upon the site of the lesion, below the lesion you will have upper motor neuron finding, we have already mentioned those. Plantar will be extensor and person will have a circumduction gait. So this will be very, very typical. At the level you will have a lower motor neuron damage, above the level it will be normal, and below the level of pyramidal tract damage it will be always upper motor neuron findings. If only one limb is involved, monoplegia. If both lower limb involved, it is paraplegia. Very frequently it will be in a spinal cord or maybe in a peripheral nerve. Monoplegia is very frequently in a plexus lesion where it will be lower motor neuron, or peripheral nerve, it will be lower motor neuron. And if there is a cortical damage it will be vascular etiology very frequently, and it will be upper motor neuron variety. If there is a spinal cord damage below the level, it will be upper motor neuron. At the level, it will be lower motor neuron. And this can be compressive or non-compressive. And once in a while, you can have pure motor involvement, which will be lower motor neuron variety, where you get the damage to anterior horn cell. Classical example will be poliomyelitis. And if you get only peripheral nerve involvement, then it will be always lower motor neuron, very commonly because of a root damage or plexus damage or a nerve damage or myoneural junctions. So this already we have discussed. So in upper motor neuron lesion or lower motor neuron lesion and upper motor neuron lesion, this will be the major difference. In upper motor neuron, disuse atrophy, slight power will be diminished, hypertonia, rigidity, hyperreflexia, and Babinski sign will be present, or we call plantar will be extensor. As far as the lower motor neuron is concerned, you will have a wasting, muscle mass will be reduced, power will be markedly diminished, or almost we say power zero, tone zero, flaccid, hyporeflexia, and plantar reflex will be flexor. So that will be very, very characteristic. So this already we have discussed. So this was for the quiz. So in upper motor neuron, disuse atrophy, lower motor neuron atrophy. As far as the tone is concerned, hypotonia, while here spasticity. During acute phase, hypotonia. Power wise, diminished. Here it will be almost zero, depending upon which muscles are involved. Pattern of weakness very frequently in upper motor neuron, hemiparesis, quadruparesis, paraparesis, monoparesis, etc. While very rarely it can be generalized. Good number of time it is predominantly proximal or predominantly distal and local. Abnormal movement, particularly clonus, will be present very frequently, while here you will demonstrate fasciculation. Babinski sign will be extensor or Babinski sign will be present, while lower motor neuron it will be mainly flexor. Dip tendon reflex will be brisk and clonus will be invariably present, while in lower motor neuron it is diminished or absent. Sphincter function not very commonly affected, while in case of a conus medullaris it will be very frequently affected if it is a lower motor neuron. EMG and nerve conduction study will be always normal, while invariably in a lower motor neuron you will have a nerve conduction and EMG will be very, very frequently affected. We have already discussed this particular part. Spasticity is more common with pyramidal tract, while rigidity is more common with extrapyramidal system. So now we are going to discuss regarding what we call as a most common finding in a stroke is hemiplegia. So it can be because of cerebral damage, brainstem damage, or spinal cord damage. We divide into three big groups. In cerebral, it will be always on the opposite side with upper motor neuron facial and upper motor neuron hypoglossal. In brainstem, same side lower motor neuron with opposite side upper motor neuron findings. We call as a cross hemiplegia. This will be contralateral hemiplegia. While in a spinal, it will be ipsilateral and there will be no cranial nerve involvement. So that will be very, very peculiar. So you can see here, if you get face involvement on one side and opposite side hemiplegia, this has to be in a brainstem. And if you get on the same side but lower half of the face involved, it will be opposite side cerebral damage. Very, very peculiar. So again, in a cortical damage, upper limb and lower limb usually not commonly being involved. One will be more involved as compared to other. So very commonly we get a monoparesis. Now, if you get the damage in internal capsule, usually you will come across with upper limb and lower limb equally involved. So internal capsule will always produce equal involvement, but no cranial nerve involvement is less likely to be in a brainstem. And if there is a cranial nerve involvement, check for the face and the tongue and you will be able to differentiate. So if we come across a person with a hemiplegia, examine the cranial nerves. There are 3 cranial nerves in midbrain, that is third cranial nerve, 7th cranial nerve in the pons, and 12th cranial nerve in the medulla. And look for the motor finding as far as upper limb and lower limb involved, coordination of upper limb and lower limb, and sensory finding in upper limb and lower limb. And you will be able to identify if a person comes with hemiplegia and person is young, chances of traumatic etiology, then we call as a atrial flutter fibrillation producing an embolic phenomena, multiple sclerosis, vasculitis, drug abuse, bleeding tendency will be the most common cause in a younger individual, while in an adult the commonest causes will be hypertension, cerebrovascular stroke due to atherosclerosis, that is thrombosis, embolism and hemorrhage, that will be more common. If there is a cross hemiplegia, it will be most likely to be in a brainstem. So all this will help you a lot while you are examining the person. So go through that. Now we'll be taking one by one. So if you get the damage in the cerebral hemisphere, so if you get the damage, there will be invariably altered level of consciousness. Your cognitive functions will be affected. Good number of times the person will present with seizures. On the opposite side, you will have sensory as well as motor weakness, maybe involving head and limbs. If you get involvement of the anterior cerebral artery, it will be lower limb more involved as compared to upper limb and face. And if it is a middle cerebral artery, it will be more of face and neck with upper limb involvement, sparing lower limb, and it will be contralateral side. Visual field will be involved if you get the involvement of the vertebrobasilar artery or posterior cerebral artery, that is involvement of the occipital lobe. And if there is a deep structure involvement, particularly basal ganglia, you can have a involuntary movement, we call movement disorders. That will be the pattern in which the person can present. So depending upon which part, frontal lobe, parietal lobe, temporal lobe, occipital lobe, if frontal lobe is involved in dominant hemisphere, you will have a Broca's aphasia. If it is temporoparietal lobe, it will be Wernicke's area, which will be Wernicke's aphasia will be more common. If you get involvement of the internal capsule, you will have more dense hemiplegia. So all this becomes very, very useful. So this frontal lobe portion, parietal lobe and temporal lobe mainly supplied by the MCA territory. This is ACA territory and this is a posterior cerebral artery. So posterior cerebral artery more of occipital lobe, MCA territory more of frontal, parietal and temporal lobe, while ACA territory mainly in the midline close to the superior sagittal sinus, which is more responsible for lower limb and bladder involvement. So that will be important clue. So if there is an ACA, opposite side lower limb and frontal lobe involvement, part of the frontal lobe. If it is a MCA territory, opposite side hemiplegia, opposite side hemianesthesia with global aphasia, because Broca's and Wernicke's aphasia will be together. If it is a posterior cerebral artery, cerebellum with homonymous hemianopia sparing, we call as macular sparing. And you will also have involvement, part of the involvement of the midbrain portion may be involved, because that is supplied by posterior cerebral artery. And if you get the involvement of the vertebral or basilar artery, opposite side hemiplegia, opposite side hemianesthesia. Sorry, no, this is something wrong. Opposite side hemiplegia, opposite side hemianesthesia with global aphasia, no. This will be if you get involvement of internal carotid artery, not vertebrobasilar artery. If you get involvement of the vertebrobasilar artery, there will be involvement of the brainstem. So in that case, you will have a contralateral hemiplegia. Sorry, some problem has been. This will be internal carotid artery. If you get internal carotid artery, it will be a combination of ACA and MCA. So opposite side hemiplegia, opposite side hemianesthesia, and global aphasia. It will be more of this, not VB territory. Vertebrobasilar artery, no, sorry, something is wrong. So that will be that particular part. I'll skip this particular. So this portion involve, lower limb involve. If you get involvement of this part, you will have involvement of the face, neck and upper limb. So this face, neck and upper limb supplied by MCA. This portion is supplied by ACA territory. So that will be very important part. So you can see that face, neck, MCA territory. This will be lower limb, which will be ACA territory. And this particular junction will be what we call as a borderline area or watershed area. And chances of damage to this area will be also quite common. And if you get the damage to this area, you will end up with Justman syndrome, which will be if there is a damage to non-dominant hemisphere, you will have hemi-neglect, dressing apraxia, constructional apraxia, and person will be also having alexia, agraphia, or calculia. That will be quite common. So agraphia or calculia, right and left confusions, person cannot identify right side and left side, and there will be also finger agnosia. And it is very common if there is a damage to the right side cerebral hemisphere, because very frequently in a right-handed person, left side is a dominant hemisphere. So that will be there. And we already mentioned that if there is a damage to the cortex, you will have seizures, you will have headache, vomiting, disorientation will be quite common, and you can have a Broca's or a Wernicke's aphasia will be also equally common. And you will have a differential hemiplegia, that upper limb will be more involved or lower limb will be more involved. We already mentioned that if you get a MCA territory, you will have a face and upper limb more involved, face and upper limb, and if you get a ACA territory, lower limb will be more involved. So that will be the portion. Almost we have covered up this particular part, lesions in a cortex. So contralateral hemisensory loss may be one of the finding in a stroke, particularly if there is an MCA territory, and we call as a superior territory, superior branch. Then contralateral hemiplegia will be also very common if there is an MCA territory, where face and upper limb will be more involved as compared to lower limb. So in an MCA infarct, chances of Wernicke's aphasia, Broca's aphasia if it is a dominant hemisphere, and hemi-neglect, that is we call as Justman syndrome if it is a non-dominant hemisphere. Then ACA infarct, motor and sensory loss in lower limb will be more common. Posterior cerebral artery, contralateral hemianopia with macular sparing will be more common because of involvement of the occipital lobe. These are all the different findings you can come across in a stroke. So in a cortical lesion, you can come across contralateral hemiplegia, cortical sensory loss, particularly localization, discrimination, 2-point discrimination, stereognosis, graphesthesia, etc. will be affected. Person can have an altered level of consciousness because of the damage to the cortex. Seizures will be quite common. And person will have a symptom signs of a raised intracranial pressure like headache, vomiting, disorientation, blurred vision, and papilledema. And because of the damage to the cortical centers like Broca's area or Wernicke's area, you can have a motor aphasia or sensory aphasia, etc. will be quite common. So in a cerebral cortical damage, altered level of consciousness, aphasia, cortical sensory loss, orientation and memory can be affected. Opposite side motor weakness, opposite side sensory loss, homonymous hemianopia will be quite common if there is involvement of a occipital lobe with macular sparing. Gaze palsy, particularly horizontal gaze palsy, because you have got a frontal eye field area in a frontal lobe. Seizures will be quite common. Among cranial nerves, usually upper motor neuron facial, it will be ipsilateral and contralateral. Ipsilateral if there is a brainstem damage, and contralateral hemiplegia if there is a brainstem damage. In a lower motor neuron damage of cranial nerves, it has to be brainstem. But if there is a damage above the brainstem, we will have upper motor neuron facial and what we call as hypoglossal, particularly genioglossus. That will be very, very common. Homonymous hemianopia, if it comes with hemiplegia, it will be in an internal capsule. Multiple cranial nerve palsy will be very common in poliomyelitis, motor neuron disease, GBS, or multiple sclerosis. More common with GBS and motor neuron disease. In poliomyelitis, particularly bulbar poliomyelitis, it can be asymmetrical, while in GBS, it will be usually symmetrical. In a brainstem damage, you can have a different artery being involved, vertebrobasilar artery. We can have a basilar artery. You can have an anterior spinal artery involvement. You can have an anterior inferior cerebellar artery or posterior cerebral artery, or you can have a posterior inferior cerebellar artery. All this artery can be involved, and depending upon that arterial involvement, you can have a part of a brainstem and cerebellum portion may be affected. In a cortex, by and large, you will have a middle cerebral artery or anterior cerebral artery or posterior cerebral artery. This can involve, posterior cerebral artery will invariably involve occipital lobe, while anterior cerebral artery will involve the midline, that is along the superior sagittal sinus, and middle cerebral artery will be mainly lateral portion, main part of the frontal lobe, parietal lobe, and temporal lobe. This will be the arterial supply, and that will be very, very useful when you get a cerebral cortical damage, you can have acalculia, agraphia, agnosia, apraxia, etc. Also, you can have, if it is a non-dominant hemisphere, you can have hemi-neglect. Particularly, person will not be able to identify right and left, and that will be non-dominant parietal lobe damage, and that is given a name Justman syndrome. So, internal capsule is a very important area because there all the pyramidal tracts is in a very small area, compacted area. So, you will have a dense hemiplegia. Upper limb and lower limb will be almost severely involved, equally involved, with hemisensory loss on the same side where you get a hemiplegia. Along with that, you can have a homonymous hemianopia. That is also very, very common. So together, when you get those findings, you should suspect internal capsular lesions. And mainly, internal capsule is supplied by the what we call as a perforating arteries or end arteries from middle cerebral arteries. So those are penetrating arteries and they are more likely to get involved. You will have damage to lower half of the face, and on the same side you will have a spastic hemiplegia of upper limb as well as lower limb. This will be in a recovery phase, but during acute episode you can have a flaccid which will soon become spastic, and plantar reflex will be extensor. So dense hemiplegia, upper limb equal to lower limb involvement, hemisensory loss, upper motor neuron facial, homonymous hemianopia will be a peculiar finding. So if you get a homonymous hemianopia, lower half of the face, upper motor neuron, same side upper limb and lower limb upper motor neuron findings, as well as tongue involved, and plantar extensor, always suspect internal capsule. As far as contralateral hemianesthesia is concerned, it will be most common in internal capsule, and it will be complete half of the face with half of the body, all sensation of opposite half. As far as the homonymous hemianopia is concerned, it will be always contralateral homonymous hemianopia. So if I get a right side internal capsular damage, you will have a left side homonymous hemianopia. Bilateral, even auditory fiber can be involved. So you can have a diminished hearing if you get internal capsular damage. Now when you come to the brainstem, it is very peculiar that cranial nerves abnormality will be there, either one or multiple. When it is multiple, invariably we suspect GBS, motor neuron disease, poliomyelitis, etc. And you will have a cross weakness and cross sensory abnormality, an altered level of consciousness because of involvement of the reticular formation. We call as activating reticular system. That will be very frequently involved. So at the level, you will have a low motor neuron type of a damage in a cranial nerves. Above the level, cranial nerves will be normal. Below the level, you will have a upper motor neuron type of a damage, specifically to facial and 12th cranial nerve. We have already done this particular in a cranial nerve involvement. So all cranial nerves are bilaterally innervated except upper half of the face, which is bilaterally innervated, but lower half of the face is unilaterally innervated from opposite side corticobulbar tract. And genioglossus is innervated by opposite side corticobulbar tract. So these two portions are innervated by opposite side only, while all other is bilaterally innervated. We are not going into detail regarding trapezius muscle. Trapezius muscle is controlled by opposite side corticobulbar tract. But after coming out from the spinal cord, it supplies the same side. So that should be kept in mind. So we have already done regarding this brainstem. I am not going in detail at present regarding a brainstem. So you will always have a contralateral hemisensory loss and contralateral hemiplegia with ipsilateral cranial nerve palsy, and it will be mainly lower motor neuron cranial nerve involvement. And you can have ipsilateral Horner syndrome if you get involvement of lower part of the medulla. So that will be very, very common. We'll not be going into detail regarding this. Now if you get a cortex involved and there is an involvement of the corticospinal tract, This is the difference between bulbar palsy and pseudobulbar palsy. So in a bulbar palsy, we know very well this is progressive bulbar palsy, so it is a lower motor neuron, while pseudobulbar palsy is a upper motor neuron damage. This is because of multiple strokes. This is because of the lower motor neuron involvement of different cranial nerve nucleus, very commonly seen in a case of what we call as a motor neuron disease. So this is a lower motor neuron nuclear damage. You will come across flaccid, that is dysphagia, dysarthria, fasciculation will be present, gag reflex will be absent, jaw jerk will be absent, etc. While in a pseudobulbar palsy, it is upper motor neuron variety, so spasticity. So spastic dysphagia, spastic dysarthria, fasciculations are absent. Usually there is no wasting, while in a bulbar there will be wasting. Because there is also involvement of the frontal lobe, you can have a labile effects, and because of upper motor neuron, gag reflex will be brisk, jaw jerk will be brisk. So here you can see if you get the damage in cortex or corona radiata or internal capsule, it will be upper motor neuron. But bilateral corticobulbar tracts, you will have a pseudobulbar palsy. Midbrain lesion, pons and medulla, we call as a bulbar palsy. So if you get that, that will be lower motor neuron. And in a spinal cord, it will be again lower motor neuron. So here in a bulbar, it will be bilateral lower motor neuron. Here it will be on the opposite side. But when you get a bilateral corticobulbar involvement, then you will have a pseudobulbar palsy. But if you get only one side corticospinal tract, it will be opposite side upper motor neuron palsy. So as you come to spinal cord, now we know that in the spinal cord it will be ipsilateral. Very frequently at the level of spinal cord you can have roots, plexus getting involved, so person will invariably present with back pain, tenderness, and on the same side you will have ipsilateral weakness, sensory findings, sparing head, as well as person will have sparing of cranial nerves. At the level it will be lower motor neuron, and below the level you will have upper motor neuron findings, and you will have a clear cut sensory loss. Below the level total sensory loss will be there, and sphincter dysfunction will be quite common finding in spinal cord damage. We already mentioned lower motor neuron and upper motor neuron findings, so I will skip that particular. We have already mentioned this particular finding. If you get half of the spinal cord, you get a Brown-Sequard syndrome. If you get a complete transection, so below the level, you will have a complete damage to all sensory, and you will have upper motor neuron findings. And if you get the damage below C5, you can have a quadriplegia, but no cranial nerve involvement, and face will be spared. So this will be peculiar findings. We'll be discussing detail when we do in spinal cord damage. So as you come to the spinal root, person will have a classical radiating pain. So if any person who comes to you with a neurological finding with a radiating pain, or we call neuralgic pain, always suspect roots or plexus involvement. There will be low motor findings on the same side with sensory findings, and there will be absence of reflexes at the level of damage, whichever reflex is involved. And below the level, ideally, as there is no spinal cord involvement, you don't have any finding. So in a spinal root findings, you will have finding in whichever root is being involved, and above the level there will be no involvement again. But particularly in case of a motor neuron disease, you can have a multiple permutation combination like upper motor neuron, lower motor neuron findings together. In case of amyotrophic lateral sclerosis, in a pseudobulbar palsy, it will be mainly upper motor neuron variety. In a primary lateral sclerosis, also again being an involvement of the corticospinal tract, it will be upper motor neuron variety. While in a progressive bulbar palsy, it will be mainly cranial nerve involvement, so it will be lower motor neuron. In a spinal muscular atrophy, again anterior horn cell getting involved, so it will be a lower motor neuron variety. And there is one special variety we call as a Madras type, which is seen in some of the family, and that was a part of again motor neuron disease. It is labeled as Madras type motor neuron disease. So this is when spinal roots get involved. In involvement of the peripheral nerves, mainly because it is only peripheral nerve, so it will be motor plus sensory plus autonomic. So lower motor neuron type of a weakness, sensory involvement in the area of distribution. Good number of time it will be glove and stocking type of distribution, and there will be loss of reflexes if that nerve is concerned with the reflex, maybe sensory, maybe motor. And as you come to the myoneural junction, once you come to the myoneural junction, there will be no sensory finding. So sensory system will be normal. There will be pure muscle involvement, maybe proximal or maybe distal. Good number of time proximal is more involved as compared to distal. And in some of the condition, distal is more involved as compared to proximal, depending upon the type of the damage. So in a myoneural junction, classical example myasthenia gravis. While in a muscle involvement, it will be bilateral, proximal more than distal, and sparing sensory system. If you remember all these things, now you can differentiate easily neuropathy from myopathy. In a neuropathy, you will have a distal more involved as compared to proximal, while in myopathy, it will be more proximal involvement. Deep tendon reflex will be absent in case of neuropathy, while in myopathy, they will be preserved. Sensory system will be totally normal in myopathy, while in case of neuropathy, always you will have some finding in sensory system. Either it is diminished or absent. Very rarely in a sensory neuropathy, you don't have sensory involvement. Absolutely uncommon. Unless it is a pure motor neuropathy. As far as the difference between myopathy, anterior horn cell disease, peripheral neuropathy, and neuromuscular junction regarding distribution, myopathy will be more proximal as compared to distal, and it will be symmetrical. While in the anterior horn cell, it is more distal, asymmetrical, and may involve the brainstem part, particularly medulla. While in peripheral nervous system or peripheral neuropathy, it is distal and symmetrical. In myoneural junction, mainly it will be involvement of the extraocular muscle, bulbar muscle, and proximal limb. As far as atrophy is concerned, you will get more atrophy in case of anterior horn cell disease, second in case of a peripheral neuropathy. But in a myoneural junction, atrophy will be absent, and in a case of a myopathy, it will be marked in case of a late stages, maybe slight in early stage. Fasciculation will be more common in anterior horn cells, may be seen in a case of a peripheral neuropathy, but in a myopathy and myoneural junction, it will be absent. Reflexes will not be affected in myopathy and in case of a neuromuscular junction disorder, but it will be affected in case of anterior horn cells and peripheral neuropathy. In case of peripheral neuropathy, in a late stage, while in a case of anterior horn cells, at the level it will be absent, and below the level it will be exaggerated. Pain will be more common finding in case of peripheral neuropathy, while you will have a localized pain at the myositis area in case of myopathy disorder if it is because of myositis. While in a myoneural junction, it is pain is never present. In peripheral neuropathy, depending upon the type of damage, pain may be present. Sensory loss and cramps. Cramps will be rare in myopathy. In anterior horn cells may be present. Peripheral neuropathy occasional, and myoneural junction usually not present. Sensory findings never in case of myopathy. Anterior horn cells also sensory loss is absent. In peripheral neuropathy always present, and myoneural junction also always absent. So this will be very important clue as far as to rule out peripheral neuropathy from other. And serum creatinine will be elevated in myopathy. Anterior horn cells may be slightly elevated. Peripheral neuropathy will be normal. Myoneural junction, it will be normal. So this becomes an important clue to differentiate between all. All those whatever we have mentioned, I've covered here. I'm just putting this at your leisure time. You can go through. This is cerebral cortex, corona radiata, internal capsule, midbrain pons, medulla, spinal cord, peripheral nerve, myoneural junction, and muscle. And here I've taken the findings. Level of consciousness, aphasia, sensory, cranial nerves, power, tone, dip tendon reflex, plantar, atrophy, sensory finding, hemianopia, cerebral lesion, and trophic ulcer. So just at your leisure time, you can go through. This is a very good slide. It will very helpful to you while localizing the lesion. And when we come to cerebral palsy, particularly, this is a disease which is very commonly seen in a neonates, and it is a permanent non-progressive brainstem brain damage, which is because of prenatal or natal or postnatal damage, and it can result into spastic variety or a dyskinetic variety or an ataxic variety, and it is a non-curable. That's why it is called permanent, and it does not progress. So it is a typical permanent non-progressive non-curable. So permanent is non-curable and it is non-progressive. So it is a lifelong. And damage does not worsen. So it is a non-progressive. And it is by and large congenital, very rarely acquired. And among acquired because of the damage to the brain after delivery. And it can be multiple different types of presentation. It can be upper limb and lower limb involved, we call it hemiplegic, which can be spastic variety. You can have both upper limb and lower limb involved, where lower limb is more involved as compared to upper limb. We call it a diplegia. And if all the four limbs are involved and almost nearly equally involved, we call as quadriplegia, and they will be all spastic variety. If we get involvement of the basal ganglia, then we can have dyskinetic variety of CNS presentation, which can be athetosis or dystonia. And if there is a cerebellar involvement, it will be ataxic variety of neurological findings. So this will be the presentation what you come across in a cerebral palsy. So we have mentioned antenatal causes, 80% of the time infections like measles, shingles. It can be because of diabetes, toxemia of pregnancy, RH incompatibility. This will be all in antenatal care, and almost 80% of them. Intrapartum, very frequently because of asphyxia or birth injury or premature delivery. And in a postpartum, brain infection, head injury, severe hypoxia, some toxicity, intracranial hemorrhage, or hyperpyrexia. So I end my lecture here. If you pay attention to this, you will be able to pinpoint where is the damage, why is the damage, and what is the type of damage. So go through again and again. You will be able to remember all those clues. What will be the finding if there is a damage to cerebral cortex? What will be the finding if there is a damage to corona radiata, internal capsule, spinal cord, anterior horn cell, peripheral nerves, etc. So do remember this. So thank you all for taking out time. I know that your time is valuable. I appreciate that you have spent some of the time with me.